Welcome to Journal Club, New Insights in Transthyretin Amyloid Cardiomyopathy, ATTR-CM, Diagnosis and Emerging Therapies. In this episode, Attractive Therapies on the Horizon for ATTR-CM, Dr. Kevin Alexander and Dr. Akshay Desai discuss some of the recent developments in the therapeutic landscape and look at some exciting presentations coming out of the 2024 International Symposium on Amyloidosis. Journal Club is developed by Projects and Knowledge powered by Kaplan and is part of a continuing medical education series. This independent CME-CE activity is supported by an educational grant from Bridge Biopharma Incorporated. Information about the faculty and disclosures can be found at journalclubpodcast.com/ATTR-CM2. You can use this link to receive your credit and evaluate this program. The URL can also be accessed in the episode notes. Dr. Alexander is an assistant professor of medicine at Stanford University School of Medicine and a member of the Stanford Amyloid Center and Stanford Cardiovascular Institute in California. Dr. Desai is an associate professor of medicine at Harvard Medical School and medical director of the Cardiomyopathy and Heart Failure Program in the Advanced Heart Disease section of the Cardiovascular Division at Brigham and Women's Hospital in Boston. I am your host, Candace Hoffman. Dr. Desai will begin our discussion.
So welcome back, Dr. Alexander. Kevin, it's great to see you, or to be with you again on this second podcast in this series on new insights into ATTR diagnosis and emerging therapies. Today's podcast is going to focus on treatment strategies for ATTR cardiac amyloidosis, and specifically on the expanding horizon of new therapies for ATTR cardiac amyloid and how we might implement a treatment strategy in clinical practice. So welcome back, Kevin. Look forward to this conversation and some of the insights that you might bring from recent meetings and the ones to come on how this therapy is evolving rapidly in this space.
Looking forward to the discussion too, Akshay. And I think it's going to be a nice extension of the first podcast where we really delved into the diagnosis and nuances of identifying people with ATTR. It's a really exciting time now that we have therapies to act on as we identify patients.
Yeah, so maybe with that in mind, I think before we get into the very nitty-gritty specifics of therapy, maybe you can sort of outline a little bit for the audience what it is that we're trying to achieve with treatment in cardiac amyloidosis. Are we aiming for cure? Are we aiming to reverse the disease process? Aiming for other outcomes? What are the goals of therapy?
Yeah, great question, Akshay. And I think as clinicians, the holy grail will be to achieve curative therapies one day. But I think that keeping in mind that just several years ago, this was a disease that didn't have direct disease-modifying therapies. We've made a lot of steps, and so just to kind of quickly summarize the pathogenesis of transthyretin amyloidosis, this is a protein. Transthyretin is a protein that's produced in the liver. Is normally secreted as a homotetramer, so four similar pieces that are closely bound together, and they transport vitamin A and thyroid hormone throughout the body. And in people that develop amyloidosis, these tetramers dissociate into monomers, which are thermodynamically unstable and have a propensity to aggregate and misfold and form amyloid fibrils. And so the therapies that have been developed, a lot of them kind of in late stage or current development, target the production of transthyretin. So either reducing the amount of TTR tetramers that dissociate into monomers, or reducing the production of transthyretin in the liver. And so with those mechanisms of action, one would anticipate that these therapies work predominantly by reducing or hopefully nearly shutting down production of transthyretin and further amyloid formation. So highlighting the fact that it's important to diagnose patients early, because these therapies probably have less impact on actually removing fibrils or leading to remodeling.
I think that's a great overview and really highlights the key role of protein misfolding as kind of a target for therapy in this disease. And I think you've nicely given us a skeleton framework for thinking about the therapies we're going to be talking about, which include those that stabilize TTR and prevent the deposition of those unstable tetramers, and then the others that silence TTR production. And maybe we can take those in sequence, and you can tell us a little bit about the landscape of more specific treatments that are available. And just to structure this discussion, maybe we can start a little bit with, start first with the stabilizers, and then we can move forward and talk about silencers, the RNA and ASO targeted therapies. And then maybe the last part of the discussion, we can talk about what else might be coming on the horizon, if that's a reasonable framework. So maybe you could start, Kevin, and give us a sense a little bit about what is available for TTR stabilization, and then we can talk a little bit about the specific data that we have regarding efficacy in ATTR-CM. And I should tell our audience that we're going to focus here just on the ATTR variant of therapy. There's a whole nother talk to be had about treatment of AL amyloidosis that affects the heart, and that's a separate topic we won't cover today. So you want to start us out, Kevin, there on TTR stabilizers?
Yeah, so transthyretin stabilizers. So these really target the rate limiting step in terms of amyloid formation. So that step of TTR tetramers dissociating into monomers. We know that that's kind of the initial and important step for later going on to develop amyloid fibrils. And I think from a scientific standpoint, development in this space is very interesting because it's insights from a variant found in nature. And so we think of a lot of TTR mutations as having a destabilizing effect on the tetramer and promoting amyloid formation, but there also are instances of super stabilizing variants. So the T119M variant actually has a super stabilizing effect. And clinically, what's been observed is that those individuals have a resistance to developing amyloid formation. And so that led to the hypothesis that if you could develop a small molecule that can stabilize the tetramer, it would have a similar or mimicking effect as this naturally occurring TTR super stabilizing variant. And so currently the only FDA approved drug for ATTR cardiomyopathy is a drug called tafamidis, which is a small molecule that stabilizes the TTR tetramer. And this was the efficacy of this treatment was confirmed in the ATTR-ACT trial that came out several years ago. And this was a phase 3 trial, randomized placebo-controlled study looking at individuals with ATTR-CM, either wild type or hereditary, and looked at survival and cardiovascular hospitalization at 30 months. And there was a dramatic reduction in not only mortality, but also cardiovascular hospitalizations, with survival curves separating at 18 months. And so this ultimately led to this tafamidis being FDA approved, and now we've been using it clinically for several years. I think it's important to note, as I mentioned earlier, that we think that this medication works predominantly by reducing new amyloid formation. And so in terms of its impact on amyloid that's already deposited in places like the myocardium, it's less clear how much of a clinical benefit there is there. And certainly in the ATTR-ACT trial, it appeared that people that had more advanced disease did not derive the same benefit from therapy as people that had earlier stage heart failure and cardiomyopathy.
So Kevin, before you move forward, let me ask you a few things about ATTR-ACT. One is, what do you make of the separation of curves kind of later in the trial, and how do we understand that delayed effect on mortality? And then I guess the other question is there any difference in the tafamidis formulations that are available, and is there a dose effect?
So in terms of the curve separation at 18 months, I think reflects the fact that this is working on preventing new amyloid fibrils rather than directly affecting amyloid that's already in the myocardium. And so I think if the natural history of this disease is that you'll continue to develop amyloid fibrils, continue to have worsening cardiomyopathy, restrictive cardiomyopathy type of phenotype. And so tafamidis is really blunting that progression. And so this is a process that amyloid is a process that probably occurs over many years. And so similarly, kind of modifying that disease, those disease manifestations is probably on the order of many months to years rather than days or weeks, which sometimes we can see in other kind of heart failure therapeutic spaces. As you pointed out, in the ATTR-ACT trial, there's two different doses of tafamidis that were studied, the 20 milligram and 80 milligram doses. And in the study, in the 30-month study, pre-specified study, there wasn't a difference between those two dosages. Later data in the extension study supports that there is incremental benefit to that 80 milligram dose over the 20 milligram. I think kind of supporting the idea that more stabilization is better for modifying disease outcomes, and it's really a matter of looking out far enough, and also the severity of the ATTR patient population you're looking at.
So, before we get onto the other drugs in the arsenal, since this is the one we have approved, can you tell us a little bit about, how do you approach the use of this drug in practice? Because it's pretty expensive, right? So how do we, any tricks for our audience about securing the drug for your patients?
Yeah, it's a good question. I mean, I think that is one of the challenges, certainly with something that's been shown to have a very potent treatment effect, we want to, have ensure access for all of our patients, and cost has remained a barrier in some instances. So, I don't have great advice, I guess, in terms of improving access here, because I do think that, we do have, unfortunately, some patients that where this is cost prohibitive. But I will say that I think this is where, like a lot of scenarios in caring for ATTR patients, having a multidisciplinary team, and that includes pharmacists and nurse coordinators, to really kind of help navigate the prior authorizations and kind of steps to getting this therapy, I think, are really important. And so I would definitely advocate for kind of additional resources to your heart failure clinic to support taking care of these patients, because I think there's the clinical need, of course, because they a lot of times have significant heart failure symptoms and need close monitoring. But then there's also the access to therapies, and certainly I think that dedicating some resources to that is really important.
And then I think, the other thing that will drive costs down is hopefully the entry of other agents into the market and that make it more competitive. There is one low-cost option available that we used to offer for treatment of ATTR amyloidosis. I guess I wanted you to comment a little on this stabilizer, diflunisal. What is it, and how do you think about its role, or is there any residual role now that we have tafamidis?
Yeah, so diflunisal is a non-steroidal anti-inflammatory drug, and it was identified in kind of a large chemical library screen to happen to have TTR stabilizing properties, and so quite potent in vitro assays. We have some randomized clinical trial data in the neuropathy space where it looks like it's clinically effective. We never had a randomized controlled trial for an ATTR cardiomyopathy. But suffice to say, I think that it's clear that it has TTR stabilizing properties, and it can, I think, clinically be effective. The pros would be that it's a generic drug, so it's relatively inexpensive. The major con, I would say, particularly in a heart failure population, is that it is a non-steroidal anti-inflammatory drug, which we typically try to avoid in heart failure patients and those with renal dysfunction. So I think that those are some of the big limiters. I think when we didn't have tafamidis, it's better than nothing. But now that we have tafamidis that has a very clean safety profile, I would say that the instances I would think about diflunisal would be, number one, if someone had very kind of mild heart failure symptoms and tafamidis is cost prohibitive, then that's better than nothing in terms of stabilizing TTR. And then an area that we don't have a lot of data on are those individuals that have the TTR, a pathogenic TTR variant, but who are asymptomatic. So these might be family members of hereditary ATTR patients, and you screen them and there's no evidence of amyloid there. The question of, do you start preventative treatment in those patients? Or do you watch and kind of wait to see if they develop symptoms? Because the penetrance of these TTR variants is incomplete, so they may never go on to develop amyloid. So we're kind of, until we have better data, it's kind of hard to commit to treating everyone in that preventative fashion. So in that case, that using diflunisal might be a nice kind of balance in terms of offering that protection without necessarily exposing people to an expensive drug or something that has significant complications.
I think you're really building the great case that you made for the multidisciplinary team, because I think you start to see the complexity of this, first identifying the patients, then identifying the variant, and then potentially needing to care not just for the patient in front of you, but for the assembled family who might be at risk in a patient with familial disease. So, I think the topic gets more complicated with the availability of other therapies on the horizon. And I think one important topic to discuss before we move off the stabilizers is the new data regarding use of acoramidis. So maybe you can tell us a little bit about what's different between acoramidis and tafamidis, or are they, and what we've learned from Attribute and its trials.
Yeah, so I think preclinically, acoramidis, or what as it was formerly known as AG10, was developed through a small chemical library screen looking at compounds that can stabilize not only wild type ATTR, but some of the variants like V122I potently. The pivotal phase 3 clinical trial looking at acoramidis was resulted last year, and then that's the ATTRibute-CM trial. Pretty similar design to ATTR-ACT, in that this was looking at people with ATTR cardiomyopathy, either wild type or hereditary disease, and looking out to 30 months for outcomes. And in the Attribute trial, they met their primary composite endpoint that included mortality, cardiovascular hospitalization, 6-minute walking, KCCQ. I think it's notable that the event rates in this trial were very different than they were for ATTR-ACT, much lower event rates. And I think reflects all of the advances in identifying patients and treating patients that have kind of transpired since the original ATTR-ACT trial. If you look at the survival for the tafamidis treated patients at ATTR-ACT, there was worse survival there than the placebo group in the Attribute-CM study. So I think really highlights this kind of a different era for amyloidosis care, ATTR amyloid care. And so it does make that a little bit challenging to infer cross-trial comparisons between those two therapies. I think it's very clear that acoramidis is a potent stabilizer and led to marked improvements in hard cardiovascular outcomes. And at the recent International Symposium on Amyloidosis, there was some subgroup data that came out of the Attribute study that kind of honed in a little bit on some of these characteristics of acoramidis and how it performs. So I'm happy to talk about that further, but I'm curious what your thoughts are, Akshay, in terms of tafamidis and the more recent Attribute data.
Yeah, well, I think there are a couple of general thoughts. I think one is, because of the challenges in access to these medications and the potent effects that they have on prevention of disease progression, I think it's really a welcome opportunity to have a second drug on the market. And I think the other thing that's very exciting about the Attribute trials, I think, has been learning a little bit more about this issue of how we begin to assess the response to treatment. And I think you've highlighted some of the data from these recent meetings that I'm sure you'll speak to in a moment. But I think the ability to begin to select out, who is actually having a favorable treatment response in patients with amyloid, I think that's another real insight from the trials. I think one of the challenges we're going to have is that we now will have data from two separate trials that are placebo-controlled of TTR stabilizers, and I think the question will be, whether there's a reason in any given patient population to choose one agent over the other. And I'm curious about what your thoughts are, as we expect to have this in hand soon commercially. So is there a profile of a patient you think you would reach for acoramidis over tafamidis? Are there advantages to one over the other that you can imagine?
Yeah, great and complex question to kind of unravel decision making between those two therapies. And ultimately, I think this is where getting more data, information from the Attribute study, getting more experience, real world experience, post hoc experience, will really kind of help us identify when and where to think about these individual therapies from a clinical standpoint. I think one big consideration kind of outside our clinical decision making, of course, is going to be that cost and access piece, which we'll see kind of how that unfolds. But assuming, say, they're both have similar costs and similar access, I think it's really going to take some time to kind of unravel, the scenarios that you outlined. That being said, I think that this is where, like you touched on, better understanding measures of disease progression and kind of surrogate markers of hard cardiovascular outcomes in this disease area are going to be important to help decide when, say, you start someone on a therapy, are they responding to it? Is it time to think about a switch or some kind of adjustment to therapy? This is something that's going to become more and more relevant as additional treatments become available. And so, I'll touch on some of the data that came out of the ISA meeting from the attribute study, which I think are starting to get at some of these areas in terms of understanding treatment response, beyond just cardiovascular mortality and hospitalization. Some of those data, for example, I think that were pretty interesting and kind of warrant further, thought, would be this idea of looking at change in serum transthyretin after starting stabilizer therapy. So we typically see, and this is the same with tafamidis, that after starting a stabilizer, the patient's serum transthyretin level increases. And that's probably because you're getting less breakdown of those tetramers. And so you have a higher steady state TTR. I don't think there hasn't been a lot of data of, well, it increases, but if it increases by 10% or 20% or 30%, what does that mean in terms of hard clinical outcomes? And so some of the data that was presented at ISA looked at baseline serum TTR levels and increase in serum TTR at 28 days in the attribute patients, and looked at the associations with various cardiovascular outcomes. And there was a clear association for every 5 milligrams per deciliter increase in serum TTR. There was a significant reduction in mortality, as well as cardiovascular hospitalization. So I think that those type of data are helpful for us as clinicians and for patients after starting treatment, that you have a relatively early data point at 28 days to say, well, your TTR increased by this much, and here's data that it links that to reductions in hard cardiovascular outcomes. And so I think that might be one way to kind of get an understanding of how these various stabilizers perform in terms of kind of predicting downstream hard cardiovascular outcomes. I think from an imaging standpoint, cardiac MRI has garnered a lot of attention in terms of measuring extracellular volume as a surrogate for amyloid load. Certainly, it's had a role in the diagnosis of ATTR, which we talked about in the first podcast. But in terms of assessing it longitudinally to see if there's regression, so to speak, of amyloid, that's something that various groups are starting to investigate. There's some data that was presented from the attribute study at ACC earlier this spring, looking at their MRI subgroup population. And in the acoramidis group, there's more individuals that had signs of cardiac amyloid regression suggested by reduction in extracellular volume, which may point towards there being some positive remodeling after starting acoramidis therapy. I think certainly we need to see this in larger data sets and validated across centers, because this was a subgroup study and MRIs were analyzed as a single site. But I think that it's kind of provocative data, provocative observation that we need further attention on.
I think this is really exciting because it does, I think you pointed out very clearly in the original ATTR-ACT study that we saw evidence that this is, despite stabilizers, a progressive disease. And in fact, quality of life scores go down in both groups, although to a lesser extent in the tafamidis treated patients. And the same is true even in the acoramidis population. But here now, even though we're talking about stabilizers that intentionally slow disease progression, you're now showing that there is some MRI-based evidence in about 12% of the population that there may be undoing of the amyloid deposition in the tissues. And that points the way to the possibility of reversing disease progression, which is really exciting. Do you think that's a reasonable goal down the road? And we're going to talk about horizon therapies in a bit, but do you think that there's a point of no return in this disease, or do you think we can pull patients back even from more advanced disease as we look forward to better therapy?
Yeah, I mean, it's definitely a spectrum, but I do think that there are patients that could have reversal to some extent of their disease. It depends on how far along they are in their disease pathogenesis. And I kind of look at AL amyloidosis as a analogous disease, where in that disease, if we were able to achieve complete hematologic remission, so completely shutting down the source of amyloid production, so that in this case, the immunoglobulin light chains, there are data that show that extracellular volume can reduce over time, over many months to a couple of years, and I think reflects the fact that the body probably has some innate mechanisms for dealing with proteotoxicity and clearing amyloid. But those mechanisms can easily be overwhelmed if there's even kind of a modest amount of amyloid being produced. So I think if the current therapies and emerging therapies can shut down production low enough that you get a net kind of clearance of amyloid, there can be some patients that have some positive remodeling. And so that's perhaps what we're seeing in the MRI subgroup data from Attribute. So I think that's very encouraging, and I'm optimistic, based on some of these recent data.
So I guess with this in mind, then, when you're treating patients with amyloid with our current arsenal, you mentioned TTR levels as a potential signal, particularly with acoramidis, of benefits. So those are pre-albumin levels, right, in many laboratories, and then MRI. So with what frequency do you measure or do these things in practice, or should we think about doing them, maybe looking ahead from use of this data?
Yeah, good question. I think if you ask 10 amyloid experts, you'd probably get slightly different answers. So there's no guidelines in these areas yet. I think in terms of this change in serum TTR prealbumin, the Attribute data would suggest that even looking at 28 days post-treatment initiation, where you've reached steady state of whatever TTR rise that you expect to see, can have impactful prognostic information. I think longitudinally, looking at measures of disease progression or treatment response, probably at the 6 to 12 month mark, makes sense to me. I mean, if you look at some of these subgroup data of some of the surrogate endpoints from ATTR-ACT and Attribute, curves separate 6, 12, 18 months, somewhere in those kind of ranges. So that's kind of where I think about maybe some serial biomarker imaging type testing. There is a disease progression paper that came out of the National Amyloid Center in the UK, was published in JACO this year, that looked at measures of disease progression that were measures of disease progression. And so they showed that if you see worsening in NT-proBNP at 12 months, so an increase of 700, or a 30% increase, or if a patient has an increase in outpatient diuretic usage, those are poor prognosticators and measures of disease progression. I think those are kind of easy things to kind of think about. I think a lot of us see patients at a 6 or annual interval, and so checking NT-proBNP, being cognizant of what diuretic dose trends have been over kind of a year period, can be quick and dirty ways to get a sense of whether or not someone's stable or progressing.
Excellent. Well, Kevin, before we talk a little bit about Horizon therapies, I did want to talk a bit about this other class of therapies that we have, for which we expect some more data about clinical outcomes in the coming months, coming weeks, actually. These silencers of TTR. So can you talk a little bit about patisiran and vutrisiran, and then inotersen, which is the ASO analog, or eplontersen? How do these strategies generally work? And then what do we think they might add?
Yeah, so these are antisense oligonucleotides and siRNAs that decrease the protein expression of transthyretin in the liver. So they can reduce TTR production anywhere from 70 to 85%. And so the idea being, if you're making less TTR overall, there's less that can go on to form amyloid. There's strong data from a number of trials now for studying these therapies in ATTR polyneuropathy, that they can not only slow progression of neuropathy, but in many cases reverse some of the neuropathy severity. And so we've really been waiting to see how this efficacy in these neuropathy trials translates to cardiomyopathy population. And the first kind of phase 3 trial to look at this is Helios-B, which is a phase 3 randomized controlled trial looking at vutrisiran versus placebo. And there's some patients that were on background tafamidis in that study. They reported their top line results several weeks ago, and they met their primary endpoint. And we expect to hear more detailed information at the upcoming ESC conference. And so I think that'll be really important to see, to understand kind of the potential role of these TTR lowering therapies in the landscape of the existing stabilizers. So more to come there.
And so what's really exciting about that, I guess, is then maybe do you speculate about the possibility of combination therapy then moving forward with maybe a stabilizer and a silencer? Is there reason to think that might be a synergistic effect?
To me, it makes sense that there be a role in certain scenarios. They both reduce TTR. So neither therapy completely shuts off TTR production, at least in terms of having data support that. And so there's some residual TTR production occurring. And so a combination of therapies that address production through different mechanisms of action seems like that could have a synergistic effect. In terms of who would benefit from that, I think that if you had a very early stage ATTR patient, many of those, like clinical practice and what we observed in trials, can be pretty stable on those therapies for a period of time. And so maybe the addition of a TTR knockdown agent could be incremental. But for those patients that have a lot of progression despite being on tafamidis, for example, perhaps there is a role for adding a second therapy there. I think that some of the challenges are going to be, since these knockdown agents weren't necessarily studied as add-on therapy to background stabilizer, we'll have trial data, kind of like we were talking about earlier for acoramidis and tafamidis, where we don't necessarily have direct data to say this is the scenario when to use combination therapy or not. And so that's something that we'll need to have better understanding. And then the other important thing there is going to be cost. These are all expensive therapies on their own. So the use in combination, I think, may be a challenge from a payer standpoint.
So in the last minute or so that remains, or 2 minutes, let's say, I'd love to think a little bit with you about where we're headed in this field. So you've talked about stabilizers, old and new. We've talked about silencers and the coming data from Helios-B. And then there are ongoing trials of gene editing approaches, antibody approaches. Can you tell us a little bit about how what these are and how they might fit in? And then maybe highlight for the audience, what we should be looking for in terms of the new trials that are coming.
Yeah, so I mean, gene editing, I would think of as kind of a permanent or one and done silencer. So as we get data for the role of silencers in ATTR-CM, I think we'll get a better understanding of what the treatment effect potentially is for gene editing. And if anything, the treatment effect for gene editing might be greater because it does lower TTR a little bit more than the currently available ASOs and siRNAs. And so I think that kind of would fit into that family of therapies. The antibodies are kind of earlier stages of development. We're just starting to see phase 3 trials roll out. And the idea there is that these are monoclonal antibodies that bind to epitopes on misfolded TTR and amyloid fibrils to hopefully promote clearance of these amyloid fibrils from tissue. So really addressing that piece of you already have amyloid deposition in the myocardium. You're on treatments that help produce production, but what about the amyloid there? Can we kind of directly intervene upon that? And so that's what these antibody therapies are looking at. And I think that we had encouraging data from the UK of these naturally occurring antibodies that were reported to lead to regression of amyloid. That was reported in a New England Journal letter. And so that, I think, gives a little bit of proof of principle that, an antibody-based strategy for removing fibrils could be an effective complement to the existing therapies. So I think one can envision that it's something that kind of would be added on to other therapies that, really focus on the production end.
So here again, now this horizon hope that we might be able to actually undo some of the disease that's already established over time. And I think we'll probably have to close our discussion there. Kevin, you've given us a huge overview of a range of therapies, both existing and coming, and how they might play into the effective management of patients with ATTR cardiac amyloidosis. And I think really given us a strong rationale for being aggressive in trying to identify this diagnosis in our patients and identifying the disease early enough such that deployment of these therapies might be effective in stalling progression and preventing the end-stage disease where we have very few treatment options still available. I think you've also given us some context for thinking about how it is that we might monitor the treatment response and begin to think about the opportunity for combination therapy. I wonder if, as we close, you have any general thoughts for the audience about amyloidosis, the epidemiology, the diagnosis, the treatment What are your closing thoughts for our group?
Yeah, actually, I mean, I think that we've seen an explosion in terms of the number of cases, and I think reflects the fact that there's increasing awareness of this disease and the overall trend, and hopefully it will continue, is that we're diagnosing patients earlier. And so I think just like if we look at a space like coronary artery disease, where we focus a lot on prevention, we still have people that have MIs and we're dealing with ischemic cardiomyopathy, et cetera. I think the spectrum of ATTR patients that we'll see in our practice will widen from very early stage, where we can see amyloid on imaging, but there's no clinical manifestations of heart failure, to those that have end-stage restrictive cardiomyopathies. And so I think that will increasingly need to become nuanced in terms of fitting the right therapy to the right patient subtype, and then also having the ability to assess disease progression and understanding when to modify therapies. So I think it's a really exciting time, and it's ripe for a number of lines of investigation.
Well, I look forward to having a further conversation with you as we begin to unpack some of the new data. But for today, thanks so much for your insights, and thanks to our audience for listening.
Remember to receive your credit and evaluate this program. Please visit journalclubpodcast.com/ATTR-CM2. You can find all the episodes in this series and all of our other podcasts on your favorite podcast streaming service, or download our Morning Commute app for all of our Journal Club and Morning Commute podcasts. Thank you for joining us today.